Good evening, everyone. Good evening, our speakers, Dr. Rupak sir and KK Roy sir. So, I would like to request Rupak sir as our first speaker. Sir, you can start your presentation now.
Yeah, thank you
Good
very
evening.
much.
Thank
Good
you.
evening, sir.
Yeah, good evening, Krishnakanta. Thank you very much for to the Bayer team for organizing this meeting. Um, yeah, is my screen visible?
Yes, sir, it's visible, sir.
So, so today I'll be talking about how to differentiate between fluid compartments in clinical practice, mainly in retina practice, which is based on basically OCT. As you know, anti-VEGF treatment has been revolutionized after the advent of uh, OCT. Actually, OCT probably came first into practice, then we had anti-VEGF. So it sort of made easy for the retina specialist to treat patients because uh, you see in clinical examination there can be a lot of missets if you just treat patients based on clinical examination, but on OCT you can just quantify the amount of fluid, uh, and also you can see the retinal thickening. So these are the most important markers of treatment, modern day treatment for diabetic macular edema, neovascular AMD, and venous occlusion. So so we will try to understand the role of fluids and its impact on vision in various clinical conditions. Yeah, just give me one second. Yeah. So so yeah, so there are multiple studies which have basically looked into the impact of fluid. So View actually was a very pioneering study which have rolled into the role of aflibercept, and the post hoc analysis suggested that in a proactive treatment setting, the overall retinal fluid does not have a marked impact on vision gain in patients. The mean change in BCVA in persistent dry or not persistent dry between the patients were essentially similar. So if you stratify patients by just overall fluid status, um, it does not really make a big difference. So this analysis basically suggests there is a disconnect between anatomic and functional outcomes in patients with neovascular AMD after monthly doses. So just looking at the overall retinal fluid or overall retinal thickness as a marker for visual outcome may not be appropriate, and is important to differentiate the roles of various fluid compartments, like whether the fluid is in the in the retinal fluid or the subretinal fluid or the sub-RP fluid. So it is important to differentiate the roles of the different fluid compartments and their impacts on visual outcomes. So if you look at the retinas, the red dots are basically your intraretinal fluid. The green area is basically the subretinal fluid, and below you have the choroidal layer, or where you can tend to get the sub-RP fluid. So the presence of subretinal fluid and the absence of IRF is typically associated with a good visual outcome at baseline and throughout the treatment course. The logic behind this probably is that there is a role of this subretinal fluid to nourish the sort of photoreceptors. Uh, so uh, so now in present day clinical practice, we tend to tolerate little amount of subretinal fluid. We will not go all out just to get all the fluid out. On the other hand, if you see intraretinal fluid, we know this is going to cause damage to the photoreceptors, and so it should be always tackled very aggressively. So presence of IRF is typically associated with poor visual outcome and baseline and throughout the course of the treatment. The role of sub-RP fluid in retinal disease is yet to be elucidated, but it has been linked to poor visual outcomes if correlated with fluids in other compartments. So fluid study was basically a very landmark study from Australia, led by the group by Dr. Giles. Uh, so they had two groups of patients. One group they treated with very aggressive treatment, and another another group of patient, they were tolerating at least 200 microns of fluid. Their data suggested that aggressively chasing SRF is not associated with the functional benefit to the patients. Uh, Therefore, this is probably the first study where before that everyone was talking about that we should completely make the retina dry, but this is one of the first studies that told us that yes, we can have a sort of tolerance of for subretinal fluid. The View post hoc analysis showed that patients that had early persistent IRF had significantly lower vision gains than those without persistent IRF. So this actually was in agreement with what we see in our clinical practice, that if patients have intraretinal fluid, they tend to have poorer outcomes. So eyes with early persistent IRF were shown to have significantly lower visual acuity gains than those without. In the View study, despite there was greater resolution SRF with aflibercept than with monthly ranibizumab, there was no difference in the visual acuity at 52 weeks. So the greater resolution of SRF with aflibercept than the monthly ranibizumab was not associated with differences VA gains at the primary 8 point, providing additional evidence that residual SRF may not have a negative impact on the functional visual outcomes. Harvard study was another very large scale study, and where patients with residual IRF had significantly less improvement in vision than those with resolved SRF. Whereas eyes with residual SRF had significantly greater improvement. So basically, again and again, all these major studies are basically showing what we see in our clinic day in, day out, that patients with intraretinal fluid, cystic kind of degeneration tend to do worse than patients who have a remnant of subretinal fluid. CAT study, which was again one of the very pioneering studies, which had compared the anti-VEGFs, the three types of anti-VEGFs between the bevacizumab. 5-year post-hoc analysis of CAT highlights that the presence of residual SRF is actually detrimental to be associated with a better visual acuity. Yeah. So the clinical perspective that we gain out of this is that using anatomical features to assess treatment response, priority should be placed on resolution of intraretinal fluid. A zero tolerance approach to SRF may not be required for optimal outcomes in neovascular AMD. So what it actually means is that we should not be very aggressive towards subretinal fluid, but if we see a patient with intraretinal fluid, we should be very aggressive. Post-hoc analysis from the View provided us with further evidence that the patients with residual IRF have poorer vision, whereas patients with residual foveal SRF have better vision than those without. So in effect, it showed that eyes with any IRF had a markedly poor visual acuity at all time points than those with absence IRF. On the other hand, eyes with foveal SRF had marked visual acuity at all time points than those without non-foveal or absence of SRF. Altair study was another study, which is basically a treat and extend study, which showed that foveal IRF was associated with worse visual acuity compared with patients who had tolerated sort of with no RF. Residual SRF was again tolerated without affecting the visual acuity. So the clinical perspective that it provides is that although a majority of patients had no fluid and improved vision at each time point, a small proportion had residual IRF and had a worse visual function than those without IRF. So patients with SRF had a similar BCVA to those without SRF. So residual SRF might be tolerated without negatively affecting visual function. ARIES is another study which demonstrated that both the absence of IRF and the presence of SRF were associated with visual weaker acuity. So the absence of SRF at every time point was associated with poorer visual function than if FSRF was present, and the presence of IRF at most time points was associated with poorer visual function than if IRF was absent. So again, SRF nourishes the photoreceptor, so a little bit of it is not bad. IRF damages the photoreceptors, the molar cells of the retina, so they should be taken out as soon as possible. So how can Fluil guide the implementation of individualized treat and extend with aflibercept for patients with NMD in routine clinical practice? So in this aflibercept treat and extend protocol, treatment is usually initiated with one injection for 3 months. Then the interval is extended for 2 months. The patients will receive an injection at every visit, and at each visit, if they are able to get the same amount of anatomical success, that the same amount of fluid is there, we are able to extend the treatment interval. So treat more frequently if VA or anatomic status deteriorate, and if the anatomic status and the VA are stable, we can extend the treatment. And nowadays, I think if the patient achieves good control, stable visual acuity, stable visual acuity parameters, we can actually extend this visit up to 12 weeks, that is 3 months. So treat until stable and then extend the interval. And at any point there is a fluid recurrence, you treat the patient. So optimal management of NMD allows for maximized vision gains while minimizing treatment burden. This can be achieved through appropriate management of retinal fluid. A differentiated approach or real understanding of the fluid compartments are required, like IRF is poor, SRF is better. Sub-RP is a gray area. So implementing an individualized treat and extend regimen that allows for tolerance of stable SRF and is intolerant to IRF may allow patients to achieve their best possible vision with their longest suitable treatment interval. So aflibercept provides unsurpassed vision gains with an excellent safety profile across multiple indications, as demonstrated by wealth of data, that is RCT and real world, has been treated on more than 25,000 patients in clinical trials and more than 50 million doses. The rate of IOI in routine clinical practice is actually extremely low. In my clinical practice, I've hardly had an IOI with aflibercept. So what does this mean for patients? That wealth of data to support confidence in safety and efficacy of aflibercept. So of course, aflibercept is one of our go-to drugs when you have to treat a patient with neovascular disorders, BRVO, CRVO, and of course, diabetic macular edema. To summarize, several analyses highlight a disconnect between anatomic and functional outcomes in NMD after initial monthly dosing. A differentiated approach recognizing the clinical significance of fluid compartments is key to optimizing visual outcomes. And evidence shows that IRF negatively impacts visual outcomes, while some SRF without IRF can be tolerated. Clinical trials demonstrate that a proactive treat and extend regimen with aflibercept can maintain vision gains with some residual fluid. So to summarize, that differential approach recognize the different clinical significance of the retinal fluid compartments is important for optimizing visual outcomes while minimizing treatment burdens. Aflibercept has over 5.2 million patient years of exposure and more than 37 billion vials has been sold. And evidence from clinical trials demonstrate that an appropriately implemented proactive treat and extend regimen with aflibercept can achieve and maintain vision gains while tolerating some residual fluid. Thank you very much for your kind attention.
Thank you, sir. Thank you, sir, for your wonderful presentation on differentiating between fluid compartment in clinical practice. Now, our second speaker is Dr. Krishnakanta Roy, and sir is talking about aflibercept in DME and primary treatment or secondary option. So, I would like to request Krishnakanta sir to kindly start his presentation. Thank you, sir. Sir, you are not audible.
Hello, am I audible now? My
Yes.
screen is visible now?
Yes, sir. Yes, sir. Now audible and screen is visible also.
Good evening, everyone. Good evening for this kind opportunity. So today I am going to talk about role of aflibercept in DME. So day by day, diabetes number of patients increasing throughout the country, throughout the world. In Southeast Asia, this increase percentage near about 74% from 2019, and near about we have 88 million patient, whereas just a minute. 2019, we have 88 million patient of diabetes, and by 2045, it will go to 153 million of patient, near 74% increase of diabetic patient. And throughout the world, its number is increasing, but Southeast Asia, they affected more, and Africa also, they affected much more. So we can assume that in our country, as we call the capital of diabetes, so diabetes related complications are much more in our country also because of poorly controlled diabetes. This is one study so that the diabetic complications, there are multiple diabetic complications are vision related complications, cardiac, renal, circulatory, or food ulcer and all. So among these, mostly threatening means patient fear about this complication, that is vision related complications, that is vision loss. So in the US survey, 47% respondent they rank vision loss is the condition that may affect their day-to-day activity. So we also see in our day-to-day OPD also the friend that patients, they mostly elderly patients, they are very much frightened about their loss of vision and become dependent on other for their day-to-day activity. So for them, vision is very, very important for all of the any disease actually. So most commonly we can get the question that Dr. আমি অন্ধ হয়ে যাই না তো? So that is the mostly important. Vision is a very, very important part of their life, mostly in the elderly patients. So diabetes related complications, most concern is the vision loss. In a study or in the slide, we normally talk about 1 line gain, 2 line gain, 3 line gain, something like that. So what is the real life implications of this 1 line, 2 line improvement? So if a patient gain 1 line, that may help the patient to read newspaper or drive at difficult conditions, or especially night driving. Though driving is not a very much important point in our patient, this is mostly important for UK or USA patient. But in our patient, doing a reading is the mostly important thing that he can achieve by 1 line improvement of vision. By 2 line improvement of vision, they can do a near vision task and a little bit complex tasks like cooking, using tools, or fine things, means suturing and all. This kind of improvement they can achieve by gaining 2 line. Gaining 3 lines means they can improve, they can perceive the color very well. So this is the improvement, the meaning of real life meaning of 1 line, 2 line, or 3 line improvement in vision. Now, what is the real life meaning of the visual acuity? That means 6/6, 6/9, or 6/12. So in normally in multiple cases or multiple area, 6/12 vision we can actually getting as a limit, because if it is vision is more than 6/12, they can retain their driving license, they can have little bit, I mean day-to-day activity they can do by their own fluently. So they reduce their mental illness, or that actually reduce their dependency to others. So this is the impact, this kind of vision is impact in their day-to-day life. A patient having more than 6/12 vision or less than 6/12 vision, more than 6/12 vision, they can do their normal day-to-day life fluently, and their dependency to others will be less. So this is the importance of having a 6-12 or more better visual acuity in normal day-to-day life. Now, we have different treatment regime for diabetic macular edema. Previously, we one loading dose followed by PRN, followed by 3 loading dose followed by PRN, then fixed dose is also there. So, if we talk about different dosing system one by one, so if we have a one loading dose followed by PRN, obviously treatment burden will be less, but it is not, vision cannot be maintained, or vision improvement also not that good. If we go for 3 loading dose followed by PRN, many of us practicing these things in our day-to-day practice. So here also visual acuity or vision gain relatively better compared to previous group, but it is not that good or it is not that great visual gain will be there. Now go for fixed dosing. Most of the clinical trial, they talk about fixed dosing. Their visual outcome or visual gain is very much superior, but treatment burden is very, very high, and that is very, very difficult to follow in our country. Most of us cannot follow this fixed dosing in our country. Now 5 loading and followed by bi-monthly dosing. This is also have superior visual and anatomical outcome. Treatment burden is high, but it is not as high as fixed dosing, but it is higher than other, means 1 loading or 3 loading. Few of us, it is also we can try, we normally follow at least few of our patient. Now loading followed by treat and extend. This is the recently we talking about this regimen, loading followed by treat and extend. Many of us following these things. Here visual acuity gaining and anatomical outcome will be better. Diabetes with the severity also regressed, and treatment burden is lower compared to fixed dosing or 5 loading by monthly. Means it is treatment burden lower and outcome also good. This is is not that much. So this is a new concept we can follow right now. This is mainly followed for AMD patient, but right now for diabetes also we can follow this kind of diabetic macular edema. What happened in the diabetic macular edema? In diabetes, main problem is capillary loss actually. So due to high blood sugar level, the capillary become damaged. Loss of pericytes is also there, and capillary endothelium also lost. So capillary become damaged. So ultimately, that causing impaired blood flow. So this is the most first point: impaired blood flow that ultimately causing hypoxia. Now, if it is a hypoxic, because why hypoxia is there? Because retina have a single blood supply, first of all. Secondly, the retinal pigment epithelium, they are very much metabolically demanding tissue in the body, most metabolically demanding tissue in the body. So they are very prone to develop hypoxia. So when there is hypoxia, they actually produce vascular endothelial growth factor, VEGF, vascular endothelial growth factor, to promote the vascularization of the study of that area, so that new blood vessels grow and they can get the oxygen. So what happened? They release VEGF A, B, and placental growth factor. Now, VEGF A, B, and placental growth factor, they working on VEGF receptor 1, that ultimately leads to activations of microglia and monocytes, ultimately leads to chronic inflammation and RP cell damage. This is one path. Secondly, here we can see that this agent, along with VEGF receptor 1, VEGF receptor 2 also activated by VEGF, and they ultimately leads to endothelial cell apoptosis and loss of tight junctions, means endothelial cells vascular permeability increases. So that ultimately cause breakdown. These two means where RP cell damage called outer blood retinal barrier loss, and here endothelial cell damage, loss of tight junction, that cause loss of inner blood retinal barrier loss. So ultimately these two cause vascular leakage and edema. Along with this, there's another factor is there. VEGF also promote formation of new blood vessels. That is called neovascularization. The problem with these new vascular blood vessels is that the blood vessels are very much leaky. Their wall is not mature. Firstly, they cause vascular leakage and edema surrounding the blood vessel. That is called, if it is occurred in the macula, this is called macula, is called macular edema or retinal edema. So this is the basic pathophysiology. Here, vascular endothelial growth factor A and B also are working, along with the placental growth factor also working for this mechanism. So sometimes what happen in sometimes what happen if we block vascular endothelial growth factor by anti-VEGF agent, so placental growth factor still be available to vascular receptor VEGF1 receptor 1, vascular endothelial growth factor receptor 1. Those can promote this inflammatory process. So we have to luckily we have a agent that is called aflibercept that can block both the placental growth factor and VEGF. So that ultimately good control of macular edema compared to other anti-VEGF agent, which are purely controlling the vascular endothelial growth factor. So that's why aflibercept works a little bit better compared to other agent. Now, this is the guideline for center involving diabetic macular edema. This is from our Indian IGO. This is the Indian guideline, Indian Ophthalmic Society guideline. So intravitreal anti-VEGF agent is right now the first line treatment for diabetic macular edema. And European Union also, they advised that anti-VEGF agent is the first line standard treatment in case of macular edema. Corticosteroid is important, but it is a second line choice for the according to European Union guideline. Now, Vivid, Vista, and Protocol T, this study actually prove that aflibercept is effective and vision gain is meaningful. So you all know this study, and all the studies show that aflibercept is effect is comparable to ranibizumab, and it is visual gain is good. Now, endurance study is the follow-up study of VISTA for up to 5 years. So this study also show that aflibercept effect is maintained. So that means aflibercept effect is not only maintained for our effect we can maintain for short time, it is also maintain the visual acuity or visual gain up to 5 years. So this is a durable also. Now, this study, this is two paper actually shows us the aflibercept long-term maintenance of visual gain is much more. And what happened if a patient have to maintain 3 to 4 visits in a year, a majority patient, to reduce the burden of patient for their caregiver life. Now, Protocol T, it's a proof us that visual gain in aflibercept is superior if patient initial visual acuity less than 20/40 or 6/9. So if patient, it is compare the ranibizumab and aflibercept, it is better, effect of aflibercept is better if initial visual acuity or before treatment visual acuity is worse than 6/9. In that case, aflibercept works better. So that is also reflected in multiple guidelines. This is a guideline from EURETINA. So they also recommend that if vision is less than 6/9 or 20/40, aflibercept is the better choice. And this is same things from Asian patient. And this is Canadian journal also. Superiority of aflibercept was noted in a group of patients with worse visual acuity, baseline visual acuity compared to ranibizumab. Now, this study, this slide already is told by Rupak sir. So aflibercept is side effect is very less. You all know that IOI, chances of IOI is very less. Rate of endothelment is also very less. In summary, aflibercept can achieve meaningful visual acuity and maintain the vision, and is the treatment of choice if the baseline visual acuity less than 20/40. Here, early intensive therapy followed by treat and extend regimen can also maintain vision, reduce burden to the patient. So patient factor is important, obviously, where beyond baseline vision, such as duration and control of diabetes, also very important for the effect of diabetic macular edema, or how drug will work and on. Aflibercept is the only biospecific VEGF fusion protein that not only control the level of VEGF, it also control the placental growth factor. It works on both, so that's why it intensively control the diabetic macular edema. With proactive individual dosing, patient can maintain visual acuity gain with reduced treatment burden after 1 year of therapy. So emerging real-world study so that the aflibercept leads to good visual and outcome in clinical practice that are considered reported clinical trial. Thank you.
For the wonderful presentation. So now the platform is open for the discussion. If there is any question from audience side or any question from our guest, they can ask.
I have a question for Dr. Krishnakanto, that when you are starting treatment for patient with in diabetic macular edema versus a BRVO, which is your agent of choice in a treatment naive case, and what kind of treatment schedule will you start the patient on, like loading, treat and extend, or PRN? What is your practice that you follow?
For diabetes, I normally, if a price constraint is not there, so diabetes patient, I normally start with aflibercept, and I try to give a loading dose of at least 3 injection, and then I try to go for PRN basis. Treat and extend I am not trying right now. So first loading dose at least 3 injection followed by PRN for diabetes patient. For BRVO, I preferably go for ranibizumab first, and then again here also loading followed by PRN.
Tried treat and extend for neovascular AMD patients?
Yes, sir.
Yeah.
Neovascular AMD patient, I tried treat and extend. I'm doing that for, I have near about 10 patient, they are on treat and extend, both in aflibercept and ranibizumab. Both are experience is very good. For DME, I didn't try it, sir.
Since you work in Durgapur and you work in close association with a very multi-speciality hospital, how do you treat patients who had diabetic, need injection and have renal problems? Do you find aflibercept safe in them?
Sir, actually, in renal problem, getting clearance from nephrologist is very difficult. They don't give clearance. In here also same problem. So giving anti-VEGF in this kind of patient is very difficult, because most of the patient I try to get a clearance. But most of the time, 2 patient nephrologist give the clearance. So in that case, patient I gave aflibercept only. I gave 2 patient. The experience is very good. There is no problem. But rest of the patient, they didn't give the clearance. So I normally go for dexamethasone implant.
So basically, my experience with aflibercept has been fantastic, and you have also worked in SN for a long period of time. So by God's grace, we did not have any sort of intraocular inflammation in your practice till this time. Did you have any intraocular inflammation with aflibercept?
No, for aflibercept, no. Only till now, I have only one intraocular inflammation after giving Peganex, bolocizumab. Only one intraocular inflammation is there occurred in my practice for last 3 years. That is after bolocizumab. Only one patient, sir.
Yeah, I think these are the two main factors that actually are driver which which we actually put so much faith in aflibercept, is that it is very safe. It hardly has any interactions or inflammations or infections, and it is very robust in its activity. It will always work nicely. Yeah, it is very
Long-term
nice.
outcome is very good. Sir,
Nice.
for AMD patient, which agent you are using for first time means
So if
among
it's
all
a
these?
if it's a neovascular AMD or a PCV, I will definitely give patients the option of newer generation anti-VEGFs, which of course the aflibercept will of course very high up. Sometimes sometimes in patients who are non-responding to treatment, and sometimes when it's very chronic kind of disease and I need a very solid drying effect, that time I might think of brolucizumab. But when I treat a treatment naive patient of neovascular AMD, PCV, of course, aflibercept is going to be my first choice.
Sir, for whatever your experience about Vivasmo?
Vabismo, I have used. Yes, Vabismo I have used. My experience is not bad, but again, as I try to tell that any day, Vabismo is a good agent. It is good in neovascular AMD. It is good in DME. Sometimes it takes a little time to act. Uh, but my experience with aflibercept probably is more than my experience with Vabismo, and if I compare head to head, I think aflibercept is ahead because it's faster and longer durability of action.
Sir, which kind of patient you are trying for Vivasmo? I never gave any, I don't have any experience also. I never used. So which kind of patient you are using right now?
So sometimes in DME patients or neovascular AMD patients, I do try Vabismo, but but for PCV and other patients, my first choice would be aflibercept.
Oh, this is, you are not using this drug for treatment naive patient.
Not mainly, but treatment naive mainly I would go for aflibercept, but there are cases where I've used this. Saurabh, do you have any idea when this 8 milligram will be available to us?
8 milligram.
Sir, till now, whatever communicate with us, it takes around 3 months more to come to
Okay.
us. But in between that, you will get a revised pricing of aflibercept, which is very less. And I hope you can able to give monthly doses of aflibercept in DME also, because price is not. I hope it will be a concern.
Okay, yeah, that is an important thing. I think you
Yeah.
should communicate to all the counselors in all the hospitals, because in this transition phase, there will be a confusion, because
Right,
some
sir.
people will think that the package is still there. Some people will think that it is not there. So this
Yes.
communication, I think, is important. But I think, yes, if the price comes down, it will be really helpful to the patients. Yes.
Yes.
But with the existing 2+3 that which is thing is going on, there is also price is not that high because effective price is less until if a patient continue the treatment, then
Yes.
this I have many patients they are continuing the treatment and the effective price is also not that high
Yes. Yes.
with this.
Still, sir, some of the patient, a lot of patients are there. Around 20% patients, if you see aflibercept, and 80% patients are on other anti-VEGF because of this price only. Because upfront price is so high that patient are. It is difficult to convince those patients. So now with revised pricing, I think I think they will afford.
Yeah,
That.
yeah, that is a good news. Let us see.
Yes.
Thank you very much.
Uh,
Yeah.
Thank, thank you very much, sir, for your wonderful talks, especially to Dr. Rupak Roy, sir, and also to Dr. Krishnakant Roy, sir. And we will wind up the meeting now, and we will looking for this kind of opportunity in near future also. Thank you, sir.
Thank you very much.
Thank you.
Thanks a lot.